Good morning, everybody. And it's my pleasure to introduce Dr. Wang Wanyi from Singapore and to have a special speech for us in total knee arthroplasty nerve block. And Dr. Wang Wanyi is a senior consultant in anesthesia, also in intensive care and pain medicine. And she is currently the lead of regional anesthesia in Chengdu Shen Hospital. And she is also involved in residency education, especially in regional anesthesia. And welcome.
Right, thank you very much for that very kind introduction. Good morning, everybody. I'm Wan Yi from Tan Tock Seng Hospital. So firstly, I'd like to thank Dr. Lin, and the organizing committee for inviting me here today. It's truly an honor, as I mentioned yesterday, to be among so many esteemed and wonderful colleagues, and with all the learning and sharing of all their expertise. All right, so moving ahead, of course, I'll be focusing on updates on regional anesthesia techniques to provide effective analgesia for total knee replacements. So I have no conflict of interest to declare. Okay, so this is where I work in Singapore. It is Tan Tock Seng Hospital. It is a public tertiary hospital with 1,500 beds, and we're currently building another building with another 600 beds. So our hospital serves the central as well as northern part of Singapore, and we have a very, very large elderly population. So a large proportion of our patients come in for hip fractures and elective joint replacements. So just last year, we performed about 760 total knee replacements. And as I mentioned before, because our patients are so elderly, the median age is 68 years old, we also implemented the ERAS knee pathway in 2019, following the successful implementation of the ERAS colorectal pathway. Okay, so I'm sure we all face the same problem in all our institutions and in our countries. We all have a very aging population, and of course, there will be an increasing number of patients coming in for joint replacements. So when I first started my training, we had to rely on IV opioids, and surgeons would give their local anesthetics. And with the advent of ultrasound and technology, we then moved towards using regional anesthesia techniques with proximal blocks such as the femoral as well as the sciatic nerve blocks. So we know these blocks are excellent. They provide very, very good analgesia. But of course, with the good analgesia, we get the problem of a dense block. And that, of course, will hinder mobility as well as rehabilitation of our patients. And of course, patients can present with falls because of the quadriceps weakness given by the blocks that we provided. As mentioned yesterday, there is also a move towards ambulatory surgery where our surgeons want the patients to be mobilizing and walking on the day of surgery and even sending them back on POD 0. And at best, maybe POD 1 or POD 2. So therefore, we need to look for more targeted nerve blocks to provide good analgesia as well as no or very, very little motor blockade. So to understand which nerves we need to target for a total knee replacement, we first need to understand what the surgical approach is. So for the standard medial parapatellar approach, that is the workhorse of Varus TKR. And if a patient presents with very severe valgus deformity, the surgeons may choose to use a lateral parapatellar approach. Currently, all the literature that we read out there are mainly for the standard medial approach for a total knee replacement. Now I'm going to revisit the knee anatomy. I'm sorry if this is quite boring, but it will just be a very, very quick rehash. So the knee innervation, as we all know, is very, very complicated. And there are at least 10 nerves that we need to target. And they originate from the femoral, sciatic, as well as the obturator nerve. So this is a very busy slide. But of course, we know that the important nerves found in the anterior part of the knee are the saphenous nerve as well as the vastus medialis nerve. And these two nerves can be blocked by a very proximal approach in the femoral crease. You can move further distally into the femoral triangle. We also know that the femoral nerve also sends branches to the vastus intermedius as well as the vastus lateralis. So that's not much literature out there to tell us how important these two particular nerves are in terms of providing the analgesia to the knee. Next up, of course, we have to talk about our genicular nerves. So we have the superior lateral genicular nerve, the superior medial genicular nerves, the inferior medial genicular nerve, as well as the inferior lateral genicular nerve, as well as the recurrent fibular nerve, which come from the common peroneal nerve. Of course, we cannot forget our little friends over there, the anterior femoral cutaneous nerve. Then moving on to the back of the knee, we have the obturator nerve, as well as branches from the sciatic nerve, which will contribute to the popliteal plexus. And the popliteal plexus innervates the posterior aspect of the knee. Now let's go into a bit more detail about the three important plexuses that we have in the knee joint. So firstly, we have the subsartorial plexus, and that lies under the sartorius muscle and has contributing nerves from the femoral as well as the anterior division of the obturator nerve. Next up, of course, we have our peripatellar plexus, and that has contributions from the femoral and sciatic nerve. So to block these two plexuses, we can perform a femoral nerve block, something very, very proximal, as well as a femoral triangle block. Now moving on to our posterior part of the knee, we have the popliteal plexus, and as I mentioned before, it has contributing branches from the sciatic nerve as well as the posterior aspect of the obturator nerve. And this can be targeted with a proximal block of the sciatic nerve, IPAC, LIA, or even a high adductor canal block, which I will elaborate more later. So now moving on to the blocks we can perform for the anterior knee proper. Okay, so this, I'm sure is very, very familiar to everybody. I'm sure all of us practice and do these blocks in our clinical practice. We have the femoral triangle as well as the adductor canal block. So I'm sure everybody is wondering what is the big fuss between trying to demarcate the location of the adductor canal versus the femoral triangle. So I'd like to stress the importance of utilizing the ultrasound. Everybody has it in the institutions, you have it by the bedside, you have it in the OT. So we should use the ultrasound to properly and clearly demarcate and locate where you would want to place your local anesthetic. So in this paper, we showed the use of ultrasound to clearly show the location of the femoral triangle. And I'm sure everybody here would know where the medial border of the sartorius muscle intersects the medial border of the adductor longus muscle. That would be the apex of the femoral triangle, and it can also be known as the start of the proper or true adductor canal. And this is shown with the pink arrow over here. So in this picture, this is your start of the adductor canal or apex of the femoral triangle. Therefore, any block that you perform or you read about in literature where they place a block in the mid-thigh, that would actually be a true femoral triangle block. And as I said, what is the big deal and why do I belabor this point? So literature has shown the importance of the vastus medialis nerve in total knee replacements and providing good analgesia for your patients. So therefore, for any kind of block that you choose to perform, it is essential that the technique will actually target this nerve. If you place your injection here in the femoral triangle location, you would block your saphenous nerve as well as the nerve to the vastus medialis nerve directly. And with the amount of volume that you have as well as drug distribution, you would also indirectly block the subsartorial as well as the peripatellar plexus. If you move further distally to the adductor canal, of course you would block your saphenous nerve, but because the vastus medialis nerve lies in its own separate sheath in this particular location, you can't really be very sure or ascertain whether you are really going to block the vastus medialis nerve. So this is a meta-analysis out there, and it actually compares the true adductor canal versus the femoral triangle. And of course, we can see that there is no significant difference in pain scores between the two groups. And the femoral triangle group actually had decreased mobilization ability at 24 hours. But there is a caveat. Whenever we read papers, we just have to make sure we read it properly. So they only looked at 5 studies, and these 5 studies had inconsistent measures. The quadriceps strength could not be analyzed properly, and there was insufficient data. So we need further research comparing the true adductor canal with a femoral triangle block to truly evaluate their motor sparing as well as analgesic effects. So the difference between these two blocks, we now know the difference between these two blocks. We can now also look at the ideal or optimal volume required for each particular block. So in this systemic literature review, the authors came to the conclusion that the ideal volume for a femoral triangle block to balance its efficacy while making sure that you spare quadriceps weakness would be about 15 mils. If you give anything more than that, it will cause proximal spread of your local anesthetic and block the motor branches and causing further quadriceps weakness. For a proximal adductor canal block, 20 to 30 mils of local anesthetic would be sufficient. Next up, the authors also looked at the use of catheters. So of course, we know inserting a catheter will be perfect. You can have a longer duration of local anesthetic as well as analgesia. So they looked at papers where they added a catheter in the adductor canal plus LIA. And of course, we know that it would provide additional analgesic benefits. So I think inserting a catheter in certain patient populations, such as patients who are very elderly, patients who require high doses of opioids, those who are opioid tolerant, may benefit from a catheter insertion. Next up, I would like to touch on the femoral nerve block, the one that you perform in the crease. Okay, this poor nerve block has been left in the backseat for a long, long time. But in this paper, the authors compared a femoral nerve block to a adductor canal block and a femoral triangle block. And of course, the results comes, there's no surprise for the results. Of course, at any time point, a femoral nerve block is associated with better pain scores and of course, the lowest cumulative opioid consumption. And as you can see, the adductor canal block presents with the highest cumulative opioid requirements. And this has come as no surprise because, as we mentioned yesterday, the further you go, the more distal the block is, the worse the analgesia will be. So keeping this in mind, the authors in this particular paper then hypothesized that patients would perhaps benefit from additional pain relief if you superimpose a femoral nerve block with short-acting local anesthetic on top of an adductor canal block when patients are unable to receive a spinal and would require general anesthesia for their surgery. And as you can see, they use chloroprocaine for their short-acting anesthesia, and patients had better pain scores as well as less opioid consumption after their surgery in the PACU. So it's something to think about at the back of your mind. So if you actually have a patient coming in for a total knee replacement and for whatever reason they are unable to get a spinal and you would need to actually use general anesthesia, a short-acting femoral nerve block may benefit these patients in providing good early analgesia, reducing their pain scores and opioid consumption, while you have the longer-acting adductor canal block or the distal femoral triangle block with a longer local anesthetic analgesia. Next up, I'd like to talk about genicular nerve blocks. So these blocks were initially described to treat severe chronic pain in the knee using fluoroscopy guidance, which I'm sure many of our pain colleagues here would do. Now we have ultrasound-guided techniques which help provide excellent analgesia for the knee. So this is a pictorial image of the genicular nerves and the vessels which they travel alongside. So it's a very, very easy block to perform. You locate the bony landmarks, place your local anesthetic, hit the bone, and your local anesthetic would hydrodissect the space. But of course, watching out for vascular as well as periarticular or intra-articular punctures. Of note is the infralateral genicular nerve, which lies very, very close to your common peroneal nerve. So any volume that you give over here may cause some spillage over to the common peroneal nerve, causing unintended nerve palsy. So I think most of our colleagues would actually prefer to block the other 3 genicular nerves and leave this particular one out. So what is the efficacy of a genicular nerve block? So in this paper, the authors added the genicular nerve block to a IPAC block as well as a adductor canal block. And the results, of course, no surprise, it had opioid consumption reduction by at least 60% in the block group. They didn't find any effect on satisfaction while the patients were in hospital and at 1 week. And the 20-meter walk test was actually very similar between the 2 groups. This is a non-inferiority trial where they compared the genicular nerve block to LIA. And what they found was there was no difference in cumulative opioid consumption, there was no difference in pain score, and therefore they concluded that a genicular nerve block was non-inferior to LIA. And how is this useful for us? How is this information useful for us? So in this paper, these authors actually used 20 to 40 mils of local anesthetic, and it produced equivalent analgesia to the high volume of LIA given by the surgeon. So if you think about it, there's actually a very, very big dose reduction, and we can actually have the potential to increase the ropivacaine dose for our other blocks to increase the duration of the analgesia. Instead of performing an LIA, we can tell our surgeons, we will actually perform additional adductor canal block as well as an IPAC block without exceeding the toxic doses, especially in those vulnerable patient populations. And we can also provide very, very good analgesia for patients coming in for bilateral total knee replacements. I'm sure many of you would have similar experiences where you find it very hard to actually keep within the toxic dose with the large volume of LIA given by the surgeons. So this is something to think about. Moving on, I'd like to talk about the anterior femoral cutaneous nerves. They are our tiny little friends. So the anterior femoral cutaneous nerve innervates the anteromedial part of the distal thigh as well as the knee. And they consist of the 2 nerves. So we have the intermediate and medial cutaneous nerves of the thigh. So how do we block these little friends? So for the medial femoral cutaneous nerve, you can actually perform a proximal femoral triangle, a block at the apex of the femoral triangle, or a adductor canal block, relying on the capillate spread of your local anesthetic. For your intermediate femoral cutaneous nerve, you can actually place local anesthetic subcutaneously above the sartorius muscle. So this is an ultrasound image of what I was talking about. So as you can see, the intermediate cutaneous femoral nerves are found here subcutaneously above the boat-shaped sartorius muscle. And over here, this is the femoral triangle block. You can see local anesthetic has gone medially to the superficial femoral artery, and the saphenous nerve as well as the vastus medialis nerve have been blocked. So it's actually a very, very simple block to perform. So moving on, of course, we have to think about the efficacy and how useful these additional blocks are for our patients. So in this paper, the authors added a femoral cutaneous nerve to a femoral triangle block. And of course, they found that pain scores were reduced and opioid consumption was markedly reduced as well. So in conclusion, they found that the addition of an anterior femoral cutaneous nerve provided very effective analgesia, reduced opioid consumption, and may even enhance the immediate functional performance of your patient on the day of surgery. So as I said, it is a very simple block to perform. You require very little local anesthetic. In fact, if you actually perform a distal femoral triangle block, you can already block your medial femoral cutaneous nerve. And all you need to do is add a little bit of local anesthetic subcutaneously above your sartorius muscle. And you can actually, with that addition, provide very good analgesia for your patients. So now we'll move on to the blocks for the posterior knee. So here I'm going to be talking about the IPAC block as well as LIA by our surgeons. So the IPAC block needs no further introduction. It aims to block the popliteal plexus at the back of the knee, which I mentioned before. It needs to be performed pre-operatively. So I guess that is it may be a bit difficult depending on the logistics and how the workflow is in your particular institution. It is really quite impossible to perform it post-operatively, what with the implants as well as your bandages and the chances of causing infection to the joint. And the needle approach can be either from a lateral or a medial direction. So this is an ultrasound image of where you would want to place your probe and your local anesthetics. So what you would do is slide your probe proximally to have the view of the condyles until you see your flat aspect of your femur. And what you want to do is look for the pulsatile popliteal artery and place your local anesthetic in between these two structures. Next, moving on, we have LIA. And the constituents and additives of the LIA really depends on your surgeons, the individual, as well as the institution. So the typical volume it will consist of will be about 100 to 170 mils of mixture of local anesthetic. And most of the constituents would be ropivacaine. And the total dose would range between 250 to 300 milligrams. And of course, that will really depend on the weight of your patient. In our institution, we add ketorolac. I think that is quite common, adrenaline, as well as tranexamic acid. Surgeons would then inject the posterior capsule, the subperiosteal, as well as subcutaneous tissue before closing up. So of course, now we have to compare the IPAC versus LIA, which will be better. So in this particular paper, they found that the IPAC block in the absence of LIA improves analgesia and functional outcomes for the first 24 hours. And of course, interestingly, the IPAC block in the presence of LIA had no additional benefit compared with LIA alone. And you might be wondering, why is this the case? So it makes a lot of sense because essentially these two blocks are injections of local anesthetic into the posterior capsule. So if you perform both blocks, like in this case, you're actually blocking the same things. Okay, so it doesn't confer additional benefits, and you're also increasing the risk of toxicity and risk to the patient. Next here, these two Saudi papers which I found, they compared LIA and the IPAC block. And of course, it showed similar results where the IPAC block had more favorable results. They had superior pain scores and improved function at 24 hours in favor of the IPAC group. And why do I bring this up? So I think it's interesting because when you read the paper, the authors actually use 50 milligrams of bupivacaine for the IPAC block compared to 100 milligrams in the surgical LIA. So if you manage to speak to your surgeon and leave out the LIA, you actually have more volume and dose of local anesthetic available to perform other beneficial blocks for your patient. And the thing about LIA is the consistency. As you all know, it really depends on how good your surgeons are in performing the LIA. Some may be very, very good, some may not. It is also, the duration of analgesia is limited. And there are large volumes of local anesthetic we need to give the patient. So it increases the risk of local anesthetic toxicity. It is a blind technique. The structures are all there when it's open, but there is always a chance of causing nerve injury as well as vascular puncture. So now I'm going to move on to the dual subsartorial block. It's a somewhat newer type of block. And how did this basis of this particular technique come about? So in this particular cadaver study, they injected 10 mils of methylene blue in the adductor canal, and they found that the methylene blue spread through the adductor canal down through the adductor hiatus into the popliteal fossa. And they also demonstrated a consistent spread of the dye and staining of the popliteal plexus, as you can see over here, as well as the genicular branch of the obturator nerve in the popliteal fossa. So for this particular block, the authors described it as a combination of a distal femoral triangle and a adductor canal block. And these two blocks provided very, very good results for the patients coming in for total knee arthroplasty. So what it involves is looking for the apex of the femoral triangle, as you can see here, and moving your probe proximally about 1 to 2 centimeters to find the distal femoral triangle location. Give your local anesthetic about 10 to 20 mils of local anesthetic. Move back down to the apex of the femoral triangle and move your probe distally 1 to 2 centimeters to find the proximal adductor canal. And there they place another 10 to 20 mils of local anesthetic. So is there any evidence on how this particular block performs compared to the other techniques out there? So this recent paper they published, they compared the dual subsartorial block with a femoral triangle block as well as a adductor canal block. And interestingly, quad strength was preserved in all three groups. The DSB had better pain scores as well as at both rest and on movement. And very interestingly, there was 0 opioid use compared to a very minimal use in a femoral triangle block and the most in a adductor canal block. And of course, this is expected, as I explained before. Next up, this was very interesting. They also looked at pain mapping. They mapped out the pain that the patient felt during the testing, and they found that the adductor canal block had incomplete coverage, especially at the upper incision sites compared to the other two techniques. And finally, the DSB provided a very good block duration and the highest satisfaction scores in the patients. Now, this is the prospect paper. I think it was mentioned by Professor Kessler yesterday. It provides recommendations for pain management after a total knee replacement. And of course, a multimodal analgesic approach is encouraged, as well as a pre-op single-shot adductor canal block, as well as LIA by your surgeons. So what I'd like to stress is this paper was published in 2022. They didn't look at newer blocks such as your genicular nerve blocks as well as iPlec blocks. So I really do look forward to more updated recommendations as more evidence gets out there. So of course, talking about all these blocks, we also have other considerations. First up will be the duration of analgesia. As I read all these papers, the blocks that we provided all gave excellent analgesia at 24 hours, maybe 36 hours at best. But thereafter, there was no difference. So what can we do to increase the duration of analgesia? Because you do want your patients to be comfortable, not just in the first 24 hours. So will the use of catheters be useful? As I said, I think it really depends on your institution, cost considerations, whether you have the facility as well as the manpower to support this. And it also may go against the whole ethos of ERAS, the ERAS pathway. Should we change the local anesthetic that we're using and perhaps use something that is a bit more long-acting? You can give this a thought. And of course, I think the use of additives will be useful. So you can add in dexamethasone, dexmedetomidine to just increase the duration of action for your nerve blocks. Next, of course, we have special patient populations. So I mean by those who are very, very elderly, patients with organ dysfunction, those who are opioid tolerant, require a lot of opioids pre- and post-operatively. These patients are often excluded, when you read your papers, from all the RCTs. And I feel like these are the patients who are at risk of local anesthetic toxicity, and they are the ones who would benefit most from targeted nerve blocks because you will give them less local anesthetic and very good analgesia with just a minimal amount of local anesthetic. So this is what we do in my hospital. So I've talked a lot about many, many blocks, but in actual fact, the surgeons give their LIA, and this helps to cover the posterior aspect of the knee. We give a single-shot distal femoral triangle block, either pre-operatively or post-operatively, and of course, a multimodal analgesic regime. So these are some of our patients. See whether I can play. So this lady over here, she had a bilateral TKR done, and this is the post-op day 2, and she's walking very, very well without any aid. Here is a patient. Sorry. Okay, so you can see 12 weeks post TKR, and she's able to kneel and stand very, very well. And finally, we have our 85-year-old there. As I said, many of our patients are very, very elderly, and she's able to ambulate really well at her post-op review. So these are very, very satisfying, things to see when you realize what your analgesia, what the ERAS pathway confers to your patients. So in conclusion, I think, going through all the latest evidence and papers out there, I still feel there is no magic bullet for total knee replacement. Yes, you can, in an ideal world, you can perform all the blocks that I mentioned before, and you will, provide excellent analgesia for your patients. But as I said, we do not live in an ideal world. There will be constraints, systemic, manpower, local anesthetic. So ultimately, I think it really depends on what you want for your patient. It depends on your patient's needs, your institution's capability to support, what you choose and your analgesic pathways. And furthermore, I think it is also an ongoing discussion as well as collaboration between you and your surgeons to provide what is best for your patient. So with this, I thank you.
Thank you, Dr. Wong Wan Yi, for your presentation about the update in the regional anesthesia for total knee arthroplasty. We will give your question for after we finish for the next speaker. So I would like to introduce for the next speaker, Dr. Takayuki Yoshida. Dr. Takayuki Yoshida has completed a PhD program from the Niigata University from Japan, and he also completes in Master of the Clinical and Research from Australia. He also completed the clinical fellowship in regional anesthesia and pain medicine from Toronto, Canada. And now, currently, he is an associate professor at the Kansai Medical University, Medical Center in Japan. Okay. He also published so many papers in the literature and also invited speaker. Please welcome Dr. Yoshida.
Thank you so much for a kind introduction, and good morning, everybody. And it's a great honor to be here. I'd like to appreciate all committee members of TSRA and RA Asia. Thank you so much. And anyway, I'm going to talk about how I place a catheter for continuous adductor canal block in my lecture. Actually, I call it adductor canal block, but it's proximal adductor canal block or femoral triangle block based on the talk given by Dr. Wang Yi. So anyway, I was hanging out in the afternoon of yesterday. Sorry, I skipped the second half of the meeting yesterday. And I noticed Japanese foods are very popular, even in Taiwan. And then probably Taiwanese people should know what this food is. So this is takoyaki. And then takoyaki is originally from my current place, Osaka. And my name is Takayuki, okay? When I was working in Canada, one of my ex-colleagues called me, "Hey, Takoyaki, what was your case today?" No, I was a bit upset. My name is Takayuki, so please don't get confused. Just call me Taka, it's easy, okay? And then anyway, I have no conflict of interest regarding my talk today. So Dr. Wang Wei also touched on the history of anesthesia and analgesia for knee surgery. I will also look back the history. So before 1980s, we just provided GA and systemic opioids for perioperative management for knee surgery. And in 90s, we started combining some regional techniques such as epidural and spinal anesthesia. And in the late 90s and early 2000s, we started using peripheral nerve block techniques such as femoral nerve block and sciatic nerve block. And recently, we tended to do blocks in more distal sites. So we tended to do adductor canal block, LIA, and some motor sparing blocks such as IPAC. So anyway, this is a very, famous picture showing the sensory coverage of the femoral nerve. So you can see the femoral nerve covers the anterior side of the thigh and the knee joint, and the saphenous nerve, which is one of the terminal branches of femoral nerve, covers the medial side of the lower leg. So this paper was published in 2009, showing the adverse events caused by continuous femoral nerve blocks. So out of 1,200 patients having continuous femoral nerve block for TKA, falls requiring treatment happened in 8 patients, which was 0.7%. And this incidence of falls includes even the exposure of prosthesis because of the fall. So, and then that patient needed redo surgery for that accident. So the problem was quadriceps weakness caused by continuous femoral nerve block the patient having after surgery. So anyway, femoral nerve block can cause quadriceps muscle weakness, and then that may cause severe accidents. And anyway, this is a paper published in 2017 showing the proportion of day surgery management for THA and TKA in the US. So this was published in 2017. So the numbers in 2016 was a real figures, but numbers after 2016 were prediction numbers at the time of 2017. So in 2016, even in the US, still 85% of TKA and THA patients were treated as inpatients, but they expected it's gonna be, outpatient proportion would be becoming higher. And then they predicted in 2026, next year, more than half of patients will be treated as ambulatory cases. And then again, I was working in Canada in 2022, 3 years ago, and then I worked at Toronto Western Hospital and also Women's College Hospital, which is also a hospital in Toronto, Canada. And then in these two hospitals, more than 60% of THA and the TKA patients were treated as ambulatory cases. So, which means, especially in North American context, the major knee joint replacement surgery is gonna be, very commonly performed day surgery cases. So, the demands for motor sparing blocks are rising, especially in North America, and then probably it's gonna be a trend all over the world, I assume. So, and if we look at the fascial anatomy and the branching pattern of a femoral nerve, you will notice that mainly medial components of femoral nerve are associated with knee joint sensation. So the saphenous nerve and the nerve to bassus medialis, the medial component includes the saphenous nerve and the nerve to bassus medialis, and these two nerves are major contributor to the knee joint sensation. Then the idea of adductor canal block came in. So when the first person devised the so-called adductor canal block, they defined that block is performed at the mid-thigh level of the thigh. So anyway, I'm gonna use the word adductor canal block to indicate that block. So based on the current context on the lecture by Dr. Wang Yi, this adductor canal block is now called the proximal adductor canal block or femoral triangle block. But anyway, I will go by this word to indicate the original adductor canal block. And anyway, this technique is to inject local anesthetic into the adductor canal block, also known as subsartorial space, at the mid-thigh level. And this technique can block the saphenous nerve and the nerve to vastus medialis. So this block can provide sensory loss in the anteromedial knee joint and the medial side of the lower leg. And it has almost no effect on the quadriceps muscle strength except the vastus medialis. Anyway, this picture shows where I and we are supposed to do so-called proximal adductor canal block or femoral triangle block. So we do it at the mid-thigh level. And actually, the mid-thigh level is a few centimeters proximal to the starting point of real anatomically defined adductor canal. So the starting point, most proximal part of the true adductor canal is the apex of a femoral triangle block, where the medial borders of sartorius muscle and adductor longus merge. So, and then we do proximal adductor canal block like a few centimeters proximal to this point. And then at this point, you can see the femoral artery in the center of the sartorius muscle. And the lateral to the femoral artery, you can see the vastus medialis muscle, and then you can see the nerve structure in between artery and the vastus medialis and the sartorius muscle. And the needle trajectory is gonna be like this. So anyway, according to this picture and these anatomical pictures, mid-thigh level should be around here or around here. So that is a few centimeters proximal to the starting point of adductor canal or vastus adductor membrane. So true adductor canal block is covered by the vastus adductor membrane on its anterior part. And we do proximal adductor canal block around here because at this level, the saphenous nerve and the nerve to vastus medialis run together. So if we give local anesthetic at this level, at the mid-thigh level, we can block both two nerves with a single injection. So let's see the effect of proximal adductor canal block. So when it comes to single shots, and if we compare single shot adductor canal block and the femoral nerve block for in patient having TKA, you can see there was no difference between two groups for the pain at 4 hours after surgery, and then also for pain at 24 hours after surgery. There was no significant difference between adductor canal block and the femoral nerve block. And then this figure shows the quadriceps muscle strength after having femoral nerve block or adductor canal block. So you can see quadriceps muscle strength was way reduced after having femoral nerve block. So it was like less than 25% of the baseline value. Whereas you can see the quadriceps muscle strength after having adductor canal block was 200% of the baseline. Yeah. So of course, this doesn't mean adductor canal block can increase the muscle strength. So in my understanding, thanks to adductor canal block, patients didn't have pain after the block. And also the motor power was spared with adductor canal block. So patients became able to move their legs without pain after having adductor canal block. That's the reason why the number shows 200% of the baseline value. So the muscle strength of adductors are kind of controlled. So there was no difference between two groups when it comes to adductor muscle strength. So this is a short summary of single-shot adductor canal block. So the proximal adductor canal block has similar analgesic effects after TKA to femoral nerve blocks. And this technique compromises the muscle strength of vastus medialis only. So it can spare the strength of the other three muscles. So the maximum voluntary isometric contraction of the quadriceps muscle would be kept better than with femoral nerve block. So this technique can provide comparable analgesia with while sparing motor function compared to femoral nerve block. So anyway, let's go into the main topic of my lecture. So continuous adductor canal block. So according to the meta-analysis published in 2023, this meta-analysis concluded that continuous adductor canal block does not enhance or prolong the analgesic benefits when compared with single-shot adductor canal block for TKA. So they said the routine use of continuous adductor canal block for post-operative analgesia after TKA is not recommended. So the forest plot in this article showed that the analgesic consumption over the first 48 hours after surgery was statistically non-significant. So the diamond plot is is crossing the midline. And also when it comes to the area under the curve of the rest pain score over the first 48 hours after surgery, there was also no difference. Although we can see the trend to be in favor of continuous adductor canal block, but anyway, statistically there was no significant difference between single shot and the continuous adductor canal block. But can you believe it? Actually, I was so skeptical about this result because theoretically, always, in my understanding, always continuous form of nerve block should be superior to single shot blocks, at least for like pain relief. So I was so skeptical about this result, and then we thought probably the problem was how we place a catheter to the adductor canal block at the mid-thigh level. So I think most people insert and advance a needle towards the nerve in the subsartorial space like this. So I mean, insert a needle toward the nerve perpendicular to the nerve course. But we place a catheter like this. So we insert and advance a needle along the sartorius muscle like this, and then we try to hydrodissect the space underneath the sartorius muscle as long as possible, and then we place needle tip in the proximity of the nerve at the mid-thigh level, and then we thread a catheter through the needle, and then place a catheter tip in the proximity of the saphenous nerve at the mid-thigh level. So, I mean, our catheter insertion point is around here, so it's close to inguinal crease where we usually place a catheter for femoral nerve block. And then we advance the needle like this direction, and then we thread the catheter through the needle. So catheter is going like this underneath the skin and the sartorius muscle, and the catheter tip should be at the mid-thigh level. We confirm the location by ultrasound. So this is the video of how we place the catheter. You can see this video this video on the link related to this article as well on the web. But anyway, first of all, we place a transducer at the mid-thigh level to see the transverse image of the nerve and artery, and we then rotate the transducer to see the longitudinal image of the sartorius muscle. And then we insert an advance needle using implant technique, and then we try to hydrodissect the space underneath the sartorius muscle like this. So we usually advance a needle for like 5 centimeters from the insertion point. And once we confirm the needle tip is close to the nerve structure, just next to the artery, we give like 20 cc of local anesthetic. And after we confirm the nerve is surrounded by local anesthetic, we inject, we're going to thread the catheter through the needle. So I think probably this one is the nerve to vastus medialis, this one is the surface nerve. Of course, it's a champion video, so we cannot see the nerve always this clearly. But yeah, you can see surface nerve and the nerve to vastus medialis here. And then we thread a catheter through the needle. So now we are seeing the transverse image of the artery and the nerve at the mid-thigh level. And you can see that hyperechoic dot representing the catheter here. And then we ask somebody to inject saline or local anesthetic to see the spread happening around the catheter dot and nerve. So the catheter is inserted here and then going toward the mid-thigh level like this. So, and then we conducted RCT in patient having continuous adductor canal block after TKA. One group received adductor canal block catheter using our parallel placement technique, and the other group received catheter using ordinary perpendicular approach. And our primary outcome was catheter migration rate on post-operative day 2. Anyway, we used 0.25% of level bupivacaine 20 cc as the initial bolus, and then we continuously infused a 0.125% level bupivacaine at 4 cc per hour. And there was no bolus option or PCA option. This is what we found. Anyway, the primary outcome, catheter migration, was way lower with parallel approach. So it was 15% in parallel placement approach group, whereas it was 73% in the perpendicular approach group. Reflecting this lower migration rate, the knee flexion range of motion and, passive and active knee flexion range of motion was better in the parallel group, and also pain score was significantly lower in the parallel group. Also, patient satisfaction score was better in the parallel group. But anyway, I need to mention caveats with adductor canal block. But actually, already Dr. Wang Wei touched on this thing, so I'll go quickly. So anyway, the anterior side of the skin is innervated by anterior cutaneous branches of femoral nerve, which is not blocked by adductor canal block. So anyway, when surgeon place the first incision, the heart rate or blood pressure may go up if we do just adductor canal block. So to complement this, I usually combine anterior femoral cutaneous nerve block. It can be easily done. And then as Dr. Wang Wei showed, we can reduce pain score by combining anterior femoral cutaneous nerve block to femoral triangle block or proximal adductor canal block. So anyway, in my opinion, a catheter-based adductor canal block is still very helpful in managing acute pain after TKA. If you place catheter properly and then your institution allows it. We should place a catheter for continuous adductor canal block in the subsaltarial space along the sartorius muscle to achieve better analgesia and improve functional recovery. Thank you for your attention.
Thank you, Dr. Yoshida, for your very informative information for the presentation. Anyone has a question from the previous session, and this session we continue.
Thank you, Dr. Wani and Taka. So I have a question for both of you. We are looking at motor sparing effects. So that can be achieved also by injecting low concentration volumes at the level of femoral nerve. We don't have to necessarily go distal for motor sparing effect. The proximal low concentration approaches, do you have any experience or what is your opinion about that?
So thank you for your question. So before we started doing continuous adductor canal block, we used to do continuous femoral nerve blocks often, combined with the popliteal sciatic nerve block or tibial nerve block. So in my experience, it's just anecdotal experience, but if we dilute levobutyrocaine to, I'm not good at math, but half of 0.125%, so it's going to be 0.06 something percent. There was very little motor blockade by even with continuous femoral nerve block. So yeah, we occasionally tried that low concentration for continuous femoral nerve blocks, and then I don't know, from my perspective, it worked, yeah, to some extent.
Exploring those, do you think it is worth exploring that approach, and do multiple infections targeting smaller nerves?
So what do you, sorry, can I?
My question is, do you think these approaches are worth exploring? Looking at the pain profile and all that, using low concentration volumes at higher levels rather than going distal.
So anyway, when I do like continuous adductor canal block using my technique, or if I combine IPAC or so-called motor sparing block, I'm fond of using higher concentration like 0.25% levobutyrocaine. But actually, even in my institution, each anesthesia person has different opinion, and then like my boss prefer to dilute even with so-called motor sparing blocks, because there is a potential risk of motor sparing block by local anesthetic splitting out. Yeah.
Dr. Wani, your opinion?
Catheters, and we would use ropivacaine. So I think we gave about 0.2 or 0.1% of ropivacaine. So trying to balance that, as you mentioned, the analgesia as well as the motor blockade. And I think the patients were still able to do their exercises in the bed where they had that machine to move their knee, and they could ambulate, but with a frame, so it still had to be assisted.
I think we also need to consider, so especially elderly patients,
Yep.
even before surgery, I mean, even before having nerve block, their muscle strength was already way reduced. So in that case, even with motor sparing block, maybe we need to dilute local anesthetic.
Yep.
I have two questions to Dr. Taka and one to Wani. First of all, we also place catheters, but we also always do it out of plane. We advance the catheter out of plane. It's very easy, and I think some of this technique is but it's very interesting. And another comment on that, we have seen in your video very nicely that the tip is when you inject your local anesthetic is spreading around the saphenous nerve and the nerve towards the medially. So it was per definition not an adductor canal catheter, it was a distal femoral triangle catheter.
Yeah, actually, as I have said, it's actually femoral triangle block, not adductor canal block, based on the anatomy. But I just use the word adductor canal block because the first adductor canal block was defined as a block performed at the mid-thigh level. And also, actually, before I started my work in Canada, I used the word properly, so I called it femoral triangle block. But in Canada, for some reason, in a real clinical setting, all of them call it like adductor canal block. So then now I'm using adductor canal block to indicate femoral triangle block, especially in clinical setting. But I don't know. There are. It's controversial, I know. Anyway, I do it at the within the femoral triangle. So it's femoral triangle block. You're right.
And I also disagree with the one meta-analysis you have shown between the comparison of the adductor canal block and the femoral adductor canal block with femoral nerve block, that the analgesia was equivalent. And this was not a true adductor canal block, this was a femoral triangle block.
Anyway, at least the catheter tip is at the mid-thigh level, and then we confirm it by giving some saline through the catheter and under ultrasound guidance. So anyway, at least the catheter tip is, at the mid-thigh level, and then, it's proximal adductor canal block.
I have a question to Marie. What is your proposal if the surgeons or the orthopedics do not do an LIA? What is your recommendation then?
Okay, so if my surgeons don't do LIA, I would choose a distal femoral triangle. So that would get my saphenous nerve, my vastus medialis nerve, as well as the anterior femoral cutaneous nerves. And then what I normally would do will be for the posterior. So actually, we used to do something like a dual subsartorial. So then I would actually do a more distal adductor canal, give a higher volume to try to get the local anesthetic down the hiatus to block the popliteal fossa. So I find when we did that for our patients, it was actually very effective. It managed to block both the anterior as well as the posterior aspect of the knee.
This question is for both Wong and Takayuki. As you said, these individuals are elderly and their quadriceps strength is weak for a very long time. Even if you put a femoral nerve block and give the full concentration and produce a quadriceps weakness for the next 24 hours with a good knee brace and then frame, all of us agree that the analgesia is far superior, but it comes with a quadriceps weakness. Even though if you paralyze the quadriceps, is there any long-term functional outcome disturbance? Why to look at so critically on motor sparing in the expense of analgesia? Why not give a good femoral nerve block when it is not affecting the long-term functional outcome? So the question is, anybody looked at, if you give a good femoral nerve block, does it have any long-term outcome is affected?
Okay, I have to admit, I think that, thank you for that question, Dr. Siva. I haven't actually looked at, from the literature, when I've been looking through at all the papers, I don't think anybody had looked at that. In fact, they just, we should look at that actually. Yes, correct.
Technically, it is much easier to place a good femoral
than to find many blocks.
Short period, and the first 24 hours, they're not going to run an intermittent that. And the quadriceps is already weak for a long time. Are we really looking at a serious problem by sparing the analgesia and preserving the muscle power in the first 24 hours? This is my long-term question in my head.
Anyway, I don't know any article showing, answering your question. But anyway, I gave a talk from the perspective of RA specialist, but truth is, in Japan, patients do not go back home so early. Usually they stay at the hospital for at least 1 week. In that case, actually continuous femoral nerve block is not a big deal in Japan at least. And then my boss and I place a catheter like that, but some of my colleagues still prefer to place continuous femoral nerve catheter, and it works very well. And then, anyway, I haven't had any complaints about continuous adductor block, nor neither a continuous femoral nerve block from the perspective of our orthopedic surgeons. So which means probably there is no big difference, at least for our surgeons.
Dr. Yoshida and Dr. Wong, thank you for a wonderful speech. I'm Sean from Wanbang Hospital. So just would like to share some clinical experience in our hospital. So what we do is that we collaborate with an orthopedic surgeon, and we ask the surgeon to do a posterior capsule. So that will restrict the volume injection to 20 and then we reserve the next by injecting only the AFCA nerve, the third primary cutaneous nerve only. and then we put the ACD catheter into the canal without injecting any building pads. And what we observed is that it's only a preliminary study. We found that about 60% of patients did not require any vascular anesthesia on the first day. I think it's quite unexpected for me. Because in a lot of clinical practice, we found that although we perfectly execute and end up the canal, but there's still a minority of patients that still feel painful. And then we just give him a rescue, an AFCM block, and do a first wonder. So I think the AFCM block might be more significant than we previously expected. So we just put in oxygen to prove the observation. So that's just my sharing of experience.
Yeah, I totally agree with your comment. So, I mean, when I let our young doctors do a diaphragm block only, they will not be happy when surgeon places prostate incision because that skin area is not covered with a diaphragm block. So afterward, I started letting them to combine anterior femoral octane block as well.
One comment about the day case TKR. We are not in Germany. We are not doing this, but mainly based on the fact that the reimbursement policy is different. So we keep the patient at least 2 or 3 days in the hospital. But I'm also convinced that when you send home a patient after a total knee replacement the same day home, the post-operative analgesia management is not as good as if the patient would be in the hospital and the post-operative care. I know from my colleagues from the US, they're given 20 tablets of oxycodone and the patient are sent home. And then they are wondering why they have a problem with opioids.
I think we have totally one question.
Yeah, but thanks, Prof. Yes, I think we have the same problem as well. My surgeon, so we give the single shot, we give the LIA, they send home on the same day. Then my surgeons come up to me and say, can you think of a way to try to increase the duration of your local anesthetic? And, because my patients are still taking opioids when they go back home. And then you stare at him and you're
The other aspect that we need to look at is if there is a tissue injury and we need to protect that place at least for a wound healing during the early phase. By doing this fast tracking or looking at mobilizing that particular part, will that not increase the inflammation and delays the wound healing? Because anyway, it's a natural mechanism, even if I got injury, that everything goes into spasm and protect that area. So we are too much concerned about that and mobilizing that joint so early. I don't think, maybe there might be a difference of opinion. If somebody looks at the inflammation of the joint, which has been mobilized much earlier, or on the other hand, we give a good analgesia for 2 days and then we slowly escalate them, I don't know what will be the functional outcome. I would personally feel if for that 85-year-old lady, give her 2 days of good, intense analgesia and then slowly escalate her to her functional levels.
Yeah.
Yes.
Yeah, if I were a patient, I would like to stay.
Me too. Actually, yes, I would just receive a catheter and stay in the hospital.
Okay, can I just make one comment? I agree with both Ranjit and Shiva because we have been discussing it for a long time. One is we have obstetric patients with walking epidurals, right? They have good analgesia and we preserve their motor activity so that they can go to the washroom. They still have labor analgesia, which is provided. So it's absolutely, if you look at the corollary, it is possible that you give low concentrations and still have the motor sparing effect. Second thing is, regarding the surgery, I have patients who have come, operated for one knee 1 year back, another knee next year. First year they had no pain. Second year, for the second knee, there's extreme pain. Same nerve block was given. What's the issue? The basic essence is we are focusing all about regional blocks, but have we looked at the misalignment of even 5 degrees which have happened post-op? If the patient has severe valgus or varus, And once the arthroplasty is done, what is the alignment which these surgeons have achieved? Even if there is a 5-degree misalignment, the pain is excruciating no matter what you do. And thirdly, what Shiva was telling, these patients don't use their quadriceps pre-op. They're all on walking aids. And they have such a deconditioning pain in the beginning, before surgery. That's why they have come for surgery. Because they're not able to bear weight, bear pain. They can't get up properly. They can't walk properly. Their quadriceps are already so weak. Have we done a pre-op assessment of the quadriceps weakness that we are contributing it to the post-op? There is no control. So until unless you do a control of pre-op quadriceps and then say that yes, the quadriceps weakness is there when they are supposed to walk without support now. There's no physiotherapy which has been done for almost a month. They would not do it. How compliant would be the elderly to do those physiotherapy to have their quadriceps strength restored so that the functional mobility is restored post-op? Not much work has been done on that. So there are a lot of contributing factors. It's not only pain, it's not only motor sparing effects, there are a lot of confounding factors which we need to look at. Just like for phantom pain I was telling you, it's not the limb pain, it's not the stump pain, it is something here. So probably the direction needs to change. We need to look at more confounding factors to have a better outcome. Thank you.
Thank you so much for the two speakers, and we have lots of interesting discussion. And it's time to have our appreciations now. And I would like to invite
Professor Kessler, can you give the certification to them?
and also Professor Dai not here.
So we finish this session. For the next session will be a coffee break. So we will come back at 10:40. Okay.